Hi, I'm Dr. Elsheikh, Professor of Pathology at Cleveland Clinic, and it's my pleasure to share with you the findings of our recent publication in Cancer Cytopathology regarding molecular testing and other metrics in thyroid cytology as quality assurance measures in evaluating variation among pathologists in the diagnosis of AUS. AUS is a subjective diagnosis with a reported interinstitutional rates ranging from 1 to 20%. The Thyroid Bethesda system endorsed an AUS rate of less than or equal to 10% as an achievable target. However, lowering AUS rates without informed adjusted diagnostic thresholds can compromise the sensitivity of thyroid FNA. The aim of our study was to evaluate the overall lab and individual pathologists' AUS rates and identify QA measures that can better assess pathologist metrics compared to lab averages and published benchmarks, and eventually provide feedback to pathologists on the causes of their discrepancies. We analyzed AUS rates of 15 cytopathology boarded pathologists and correlated those with AUS to M ratio, histologic risk of malignancy, Afirma molecular positive call rate, and constructed scatter plots. We also analyzed the distribution of pathologists' TBS diagnostic categories and compared those to lab averages and correlated those with the above metrics. Our results showed wide variation in AUS rates ranging from 7 to 44% among pathologists, and our lab average was 19%. The scatter plots highlighted pathologist metrics that were outliers. AUS versus PCR plot showed negative correlation that was statistically significant. That is, higher AUS rates were associated with lower PCR. Of interest here, only 1 out of our 15 pathologists actually met the TBS target AUS rate of less than or equal 10%. AUSM versus PCR and AUSM versus ROM plots showed negative correlations, but they were not statistically significant, and they highlighted additional outliers. Analysis of the pathologist percentage distribution of the TBS categories further identified patterns and trends that explain the causes of deviations, including overcalling benign as AUS, undercalling, and mixed overcalling and undercalling. For example, pathologist number 7 on the scatter plot showed very high AUS and AUSM and low PCR, suggesting a pattern of overcalling benign as AUS. But ROM was near average, contradicting the low PCR values. TBS category distribution suggested that there was a presence of an additional pattern of undercalling malignant, suspicious, and follicular neoplasm as AUS. Pathologist number 8 theoretically had ideal metrics as AUS and AUSM closely met the TBS targets. The scatter plots showed very high PCR and low AUS compared to lab averages, and the TBS category distributions suggested that there was a pattern of undercalling across multiple TBS categories. In conclusion, correlation of AUS, AUSM, and ROM with molecular results and TBS category distributions offer a robust framework for QA. A successful QA program can provide explanations for the causes of AUS overuse and deliver feedback to pathologists on opportunities for refining their diagnostic thresholds. Thank you, and I hope you get the opportunity to read the paper in full.